from their busy schedule for this webinar. And I welcome all the attendees and delegates for this webinar. I request all the delegates to post their questions in the chat box, which will be answered at the end of the webinar, or you can directly WhatsApp on this number 9450758086. So without wasting any time, I request our organizing chairman, Professor Ajay Singh sir, to formally start the session and introduce the topic. Over to you, sir.
Thank you, Faisal. On the behalf of Uttar Pradesh, I'm so happy that today's all three speakers are very dynamic young orthopedic surgeon, and they are doing extremely well, making us proud. And this trauma web series was started with the intention so that we can spread our knowledge. That is trauma, specifically for
box. And we are happy to share that this webinar is live on YouTube, Zoom, and Ortho TV. Ortho TV for easy accessibility. We are looking forward for a great session ahead. We are really fortunate to have eminent and experienced faculty for this meeting. So without any further delay, I request our first speaker, Dr. Varun Agarwal, sir, who is a consultant orthopedic and spine specialist practicing in Bareilly. He is well-trained surgeon and specializes in the management of complex and revision spine surgeries. I welcome sir to present on the topic evaluation and management of pediatric cervical spine trauma. Over to you, sir.
Thank you, Dr. Saeed, for the wonderful introduction. And thanks to Dr. Ajay and Department of Pediatric Orthopedics, KGMU, and the UPOA for inviting us here for this nice discussing pediatric cervical spine injuries. I hope you can see my screen and I can proceed.
Yes, sir, please proceed.
Yeah, so I'm Associate Professor of Orthopedics from Rohilkhand Medical College in Bareilly. So these are the cases which we usually encounter quite frequently in our OPDs with the children presenting with all sorts of injuries. And then we are at a loss how to manage these cases and how to evaluate these cases. So I will try to put some light on this topic. So the other thing is that we always think that these patients are hopeless and nothing much can be done about the cervical spine injury cases. And this is the biggest thing, that everybody thinks that the cervical spine is only for the neurosurgeons. So it's not like that. I have no financial disclosures. So the problem of spinal injury in the pediatric age group is, this is as per the NICE guidelines of 2007, full body CT within 1 hour of presentation following a severe polytrauma in a child, and small numbers seen in single PICO department each year. So there is an inconsistent approach to these patients. And we should all remember that these children are not young adults and they need a different set of protocol and management guidelines. So usually it is a multidisciplinary approach to manage these cases. And for a polytrauma, especially for those kind of cases, different specialties need to be involved with us, such as general surgery, neurosurgery, orthopedic, pediatric radiology, PICU consultants. All should come together for management of such cases. And motor deficits without radiographic evidence of vertebral fractures or bony misalignment on plain radiographs. It is more prevalent in children, and we should be aware of this because of their variable spine, which tolerates loading and deformity. And there is relatively lax ligaments and horizontal facet joints. And in 72 previously normal children with cervical spine injury found that all those with 8 symptomatic injuries had both a high risk of injury mechanism and a distracting injury. So neck immobilization should be maintained during evaluation and management. This is of utmost importance, and a cervical collar of the pediatric size should always be available in an emergency department. So this is how we evaluate these cases. So this is an algorithm. Various algorithms have been described, the nexus criteria, which most of us are aware, but it is mostly for the elder age group. That there is no cervical midline tenderness, no focal neurological deficit, no intoxication, normal alert, no painful distracting injuries are there. Then you can clear the cervical spine. But it is of limited value in the pediatric age group with a sensitivity of 100%, but a specificity of low. It's a quite low specificity of 19%. So further studies show that nexus is 94% sensitive among children and aged less than 8 years and 100% sensitive in those greater than 8 years of age. And in a pediatric emergency care applied research network, study found that nexus criteria was 83% sensitive only. And of the 90 children missed by nexus criteria, most of them were less than 8 years of age. So these are the Canadian C-spine rules, which are more elaborate, and there has been a consensus that they are much better, and specificity is much more than the nexus, which is mostly for the adults. So this is the Trauma Association of Canada, which has given pediatric guidelines, and this is the flowchart which we can all remember and follow for evaluating such injuries. So when coming on to the radiological examination, children with the suspected cervical spine, a lateral AP, and if possible an open mouth odontoid view, that has to be the minimum 3 X-rays which are to be taken. So when do you go for these X-rays? When there is a high risk mechanism like a high speed motor vehicle collision, bicycle injury, diving or other activity, hyperextension or hyperflexion of the neck, falls greater than body height, all these which are high risk mechanisms, and all these children should receive an X-ray. When there is multiple system involved, there is a distracting pain elsewhere, injury above the clavicle level, altered mental status is there is neck pain, tenderness or limitation of movement, or there is an acute neurological deficit, all such patients should receive an X-ray series. So when we talk about the lateral X-rays, we should focus on the coverage, alignment, disc spaces, prevertebral soft tissue shadows, edge of the image. The green is the anterior vertebral line, the posterior vertebral line, and the red spinolaminar line. All should be congruent in a normal X-ray. In the AP X-ray,
Varun sir, you are on mute.
So in the AP X-ray, we should again look at the coverage, the alignment, bone spacing between the vertebrae, soft tissues, and look for the edge of the image. So this is the open mouth view, and the view is considered adequate if it shows the alignment of the lateral process of the C1 and the C2 marked in red circles, and the distance between the peg of the odontoid and the lateral masses of C1 should be equal on each side. So one may need a swimmer's view if the C7, T1 are not adequately visualized. So one may consider for a special view. And similarly, flexion extension views may also be considered depending upon the problem. Then one should be aware of these osseous variants that may simulate injury and confuse the diagnosis, and they may be normal anatomy. One should remember that the atlas has 3 primary centers of ossification. Similarly, axis has 5 centers of ossification, which I have marked in these X-rays. This is again a secondary ossification center, or the os terminale of the C2 odontoid. Again, this is the normal variants of the C1. There is incomplete fusion, and there is a cleft or a fracture. This is how you can differentiate that the cleft, the margins are quite smooth, whereas in the fracture, there is ragged fracture margins. Then this is a ossified posterior atlanto-occipital membrane. One should be aware of these routine variations. Then there is incomplete fusion of the C2. Ossific density at the cranial aspect of the odontoid process, such as an os terminale, os odontium, and an odontoid fracture, all these need to be differentiated. The anterior wedging again may be normal, or a cleft in the transverse foramen again is a normal variation. Again, you can see that there is a sort of cleft in the spinous process. This is again normal and not a fracture. Disc herniation between the ring apophysis may be there. And this is more common in the lumbar spine though. The small nodes are there. All these are normal variations. Then there may be motion artifacts also, which may confuse the diagnosis, and they should not be considered as fractures. So when should we go for a CT of the cervical spine? When there is a lower or the upper cervical spine is not visualized on the plain films, there is abnormal or suspicious cervical spine, suspicion of injury despite normal X-rays. And if the patient has a severe head trauma, basically the child would be going for a head CT, and there should be a screening protocol for all the head injury patients. That simultaneously a cervical spine screening can be done in the same sitting, because it is very difficult to move these patients again and again to the CT room. The MRI, although the specificity of the CT for bony injuries is almost 100%, MRI the role of MRI is increasing to identify the soft tissue injury. It is very sensitive, and unclear clinical significance of radiological finding is always there. So always take this with a pinch of salt. Controversy over ideal time for scanning. Some say it should be within 48 hours, or most likely it is after 48 hours when all of the edema, etc. has settled. And there may be practical difficulties in obtaining an MRI in a pediatric population, and they may require sedation or even general anesthesia. All these things need to be considered. A child with an abnormal neurological examination and those requiring imaging of soft tissues of the spinal column, these people should get MRI. Patients with a normal plain films but persistent concern for a neurological injury based upon the history, and if the patient has a prolonged loss of consciousness, all these should be sent for an MRI if possible. So this is the protocol we follow. First, there is clinical assessment, and if there is a clinical suspicion for spinal injury, depending upon the mechanism of injury, such as a road traffic accident, fall, or high energy sports injury, then clinical examination to rule out any external injury, step, deformity, etc. And then we go in for radiological CT of the cervical spine, especially in head injury or full spine in polytrauma. Arrange then MRI if clinical suspicion of injury high and patient is likely to be sedated for more than 72 hours. And if imaging should be reported promptly by a consultant radiologist, and spinal precautions to continue until imaging and complete and reports are available. Then general principles of surgical management. Goals is to improve stability of the vertebral column and to promote the spinal cord while limiting operative risks, repeated procedures, and morbidity. The approach, whether anterior or posterior, is dictated by which column is involved, and usually we go in from the column from the side, which column is involved. Anterior approach for anterior injuries and posterior approach for the posterior column injuries. And sometimes in severe injuries where there is gross instability, you may need to combine anterior and the posterior approaches. The surgical options include a posterior onlay autograft with a halo placement, posterior bone and wire fusion with halo immobilization, posterior lateral mass plate instrumentation, or an anterior cervical discectomy and fusion. So by 10 years of age, the adult height of the cervical vertebra is reached. So one may plan for adult kind of procedures, and especially the anterior approaches can be planned. For children up to 4 years old, a posterior bone cable fusion and external immobilization is preferred because of technical limitations of the plate and screw fixation. By age of 5 years, we can plan for anterior discectomy also. So these are some of my cases. This is a case of an occipitocervical anomaly, 8-year-old male, neglected trauma, 8 months at presentation, complete quadriplegia, and you can see that the occiput and the C1 have been assimilated, and C2, C3, they have been assimilated. You can see here. And this is the vertebral artery going over the posterior joint. So posterior options become quite limited. So in this case, we did an anterior approach and did a minimally invasive endoscopic removal of the odontoid, and followed by a this is the endoscopy to the C1 odontoid fracture. The 16-year-old male, history of fall while working in the field, 5 days old at presentation, again with complete quadriplegia. You can see there's a dense fracture. He was openly reduced and fixed with wiring and C1 C2 rod fixation. And again, by 4th post-operative day, you can see the recovery is quite well. And by 12th post-operative day, even he is walking without any assistance. And by 2 months, even I failed to recognize this patient in my OPD when he came for a follow-up at 2 months with full recovery. So another case of a 12-year-old male with the history of fall while climbing a tree, 20 days old at presentation, again complete quadriplegia. And you can see the anomalies here. This is how we managed with an anterior transarticular screw. And by 12th post-operative day, again, he is recovering quite well. So the take-home message is that the patient's ability to walk does not. So the take-home message is that the patient's ability to walk does not exclude a cervical spine injury. Immobilization should be maintained until there is clearance. And spinal cord injury can happen without radiological evidence. One should remember that. And you may have to adopt some different sort of strategies than adults for managing the pediatric population because of the small bone size and the unique challenges they present. So, thanks a lot for a patient hearing. So we take the...
Thank you, sir. It was indeed a very well and comprehensive presentation. Dr. Varun Agarwal, sir, is here with us. Good evening, sir. I request Dr. Anup Agarwal, sir, Secretary, Uttar Pradesh Orthopedic Association, to please say some words.
Hello, good evening, everyone. Sorry, I was a little late. Welcome to everyone. I think this is a very interesting session where we are talking about the pediatric spine trauma. And I have stalwarts of spine from UP, Varun, Shah Waliullah, and Shivam Sinha. I'm sure that we all would be benefited by their words of wisdom on spine. So thank you once again for keeping the flag high of UPOA and continuing these webinars. Thank you.
Thank you so much, sir. So now we move on to the next speaker, Dr. Shah Waliullah, sir, who is additional professor in spine unit, Department of Orthopedics, KGMU. And sir has done various postdoctoral fellowships in spine and spinal deformity. And he is a very well-trained surgeon and he specializes in the management. Over to you, sir.
Thanks a lot. Thanks a lot, Faisal, for your kind introduction. So, after getting a talk from Varun that covering from cervical spine injury, we are getting lower down to cover this thoracolumbar trauma. So, as we all know, that with the increased amount of motor vehicle accident and everything, we are getting lots of cases in our OPD. So, I'll start with few of the cases. So get to verse about what is the spectrum of the cases that we are getting in our OPD, and they are very challenging because they are different entities. They are not as same as Varun has rightly told. They are not as a young adult, so we'll have to treat him differently. So for that, we need to have a high index of suspicion. Because sometimes the presentation is like they are walking, they are coming with walking, and we misdiagnose them that they are not having any cervical spine injury or a thoracolumbar trauma, but it usually doesn't happen. So I'm going to give you a glimpse of some of the cases that we have done, so that I'm just going a practical approach. So I'll involve some of the panelists to get discussion with these cases. Okay, so just one or two cases I'm going to discuss, then I'm coming to the theoretical part, how these cases are different from adult, and what are the things that we need to remember while managing these cases, and what is the protocol, especially when to prescribe CT, when to do MRI, and all that. And then just briefly we'll discuss about the management protocol, how to proceed for these patients. So there's a 9-year-old guy that was referred to our emergency department after 1 day of cold injury due to fall from height. So he presented a significant pain at the lumbosacral region associated with a local edema, and a deformity was also present there. Neurologically, he was normal. With the Asia grade, he was not having any neurological deficit or any sort of, he was neurologically intact. So we did an X-ray of the lumbosacral region, and we found that this is a case of traumatic spondylolisthesis. And the patient was having severe pain, though the neurology was intact, but he is a young, like 8-year-old kid, a 9-year-old kid. So, and the injury was looking to be quite devastating because the patient was in severe agony of the pain, and he was having lot of pain issues, but the neurology was normal. So, what do you think? Should we? This is a CT for the same patient. The burst fracture. As we see, the whole of the cord, whole of the spinal cord has been occupied by this burst fracture, and this is, we are able to see this is a fragment that is getting anterior to the vertebra. So what's the next? Should we go for operative intervention or a conservative maneuver should be continued? I think all should be in consensus because this is a highly unstable injury. This is traumatic. This is a destruction of the pars articularis of the both, and there is a forward subluxation. And we need to stabilize this kind of patient, even if the patient is having normal neurology. Doesn't matter because if we are going to stabilize this patient so that we can able to provide a normal sagittal balance to this patient, as well as the pain can be relieved after the fixation. So we have planned this patient for the operative intervention. There were some challenges for fixing because the vertebra was getting higher. After positioning, we got this much of reduction of this patient. So we did pedicle screw fixation first at L4, then at the S1. This was intraoperative imaging after fixing. So we did like unilateral. We use reduction screws. First of all, by the right side, we have applied reduction screws and pull out the L4 partially by a cantilever mechanism. Then again to the another side, we have pulled out the vertebra by a cantilever mechanism. So we are able to get a good reduction, and as a final X-ray for this patient, having a good sagittal balance for this patient. And post-operatively, patient has got good relief in pain, and patient was mobilized after 3 days of its surgery. So another case, this one is going to be a bit interesting. I feel like it's a 4-year-old male that presented with a history of trivial fall from the bed only and presented in OPD with a pain over back. On examination, there was diffuse tenderness. There was not localized over upper thoracic spine. Neurologically is normal. So we did an X-ray, and X-ray was not found to be anything abnormal. So we did like prescribed anti-inflammatory medication with advice to do in follow-up. But unfortunately, in the follow-up, this patient presented again back pain, and the X-ray was done after 15 years. The X-ray was done, that was normal, and he was advised an MRI because he was having still persistent pain, and the MRI showed a space occupied lesion. Here we get this MRI. So there is a space occupying lesion in this patient. So as this is a case of spinal cord injury without radiological abnormality, as for these patients, there's high index of suspicion because the pain was not revolving and the patient is still having pain, but the neurology was okay this time. So we did an MRI, and because the neurology was normal and there was a space occupying, so we started steroid, and the patient got relief after starting steroid. And after 3 days, we again discharged this patient with an advice to be strictly on bed, but unfortunately, after 15 days, he presented with difficulty in walking, and he was deteriorated and landed in Asia B. Then we did a repeat MRI for this patient. So what we found that this lesion has got increased in the size, and the patient neurology is getting involved just because of this increasing expansion of this hematoma. So this is a case that require urgent intervention, because if you are not going to intervene, as patient has already got it deteriorated into Asia B. So it's a high time to think about this patient. So this is an axial views for this patient. So we plan whether to go for conservative. There's no doubt about this patient. We should go for operative intervention because the neurology got deteriorated for this patient. So we have planned for LT3 disectomy, T3 laminectomy we did for this patient at the T3, and hematoma was drained out. And there's a follow-up MRI for this patient. So as we see, this space occupied lesion has got revealed completely, and the cord has got almost complete texture in this follow-up MRI. So here is the follow-up of this patient at 1 year. This patient is walking normally after decompression. So timely intervention for these patients is required. This is so what we see that regarding the presentation from relatively simple, just a normal X-ray, and he's going to get involved in the neurology. And the other side, the patient is having an X-ray that is telling you that is having high velocity of trauma, and so that requires intervention. So we need to treat this patient very delicately and very vigilantly, because anything can lead to a devastating sequelae. Though spinal cord injuries are rare and they account for only 2 to 5% of all spine patients. I'm going to start my lecture from here with this because I am just trying to give emphasis, because they look very subtle injuries, but they are not at all that. We need to be very much vigilant. So there is high index of suspicion is necessary to diagnose pediatric spinal injury, especially in patient with polytrauma. And more so if the patient is having polytrauma, it's always a very big job to diagnose this spinal cord injury. Among various thoracolumbar spinal injury, a major difference between adult and spine is the occurrence of skyvora. I have shown you this case, skyvora. These are really one group of entity of the fracture that we need to consider for every patient. If the patient is having persistent pain and not responding, and radiologically we are not getting any problem to any abnormality. So why this patient differ from adult? Why this pediatric spine? There are certain reasons that it differs both biomechanically and anatomically, because they have shallow angulation of the facet joint, greater ligamentous flexibility, relative paraspinal muscle immaturity, incomplete ossification of the vertebra, and there is greater elasticity of the nucleus pulposus because of the high content of the water in the nucleus pulposus. So they have relatively larger head as compared to the body. So that's why they are prone for cervical injury. And they have facet joints that are relatively horizontally oriented, so that providing greater mobility but less stability. So that's why they are getting prone for the extension and flexion type of injury. So for breakage of bone, as because of frank rupture of ligament compared to pediatric spine injury. So deformation and return to normal alignment are more common in cases of pediatric spinal injury as compared to the adult spine. So this is a basic difference. These are the anatomical difference. Why these patients are different from why these pediatric patients are different from adult one. And there are few things that we need to remember while doing operative intervention. Like we should know that the spinal cord ends at the level of L3 newborn, and it should migrate during the childhood at the level of L1 to L2. By the 6 years of age, the spinal canal acquires adult volume. So after 6 years of age, you can do any procedure that requires like intervention for the laminectomy, sort of those things. And by the age of 10 years, the spine is generally similar to that of adult state. That means that the spine grows in girth only after the age of 10 years. So most of the height will be of the spine will be gained by the age of 10 years. Regarding the epidemiology, the thoracolumbar region most frequently secondary to the high-speed motor vehicle accident or a fall from a significant height. In the Western, it is different because of the motor vehicle accident, while in Indian scenario, it is mainly because of the fall from height. In our scenario, majority of the patients, they do come with a history of fall from height. It occurs in two major age groups, younger than 5 and older than 10-year-old group. There's a vis-a-vis presentation for this thing. The proportion of thoracic and lumbar fracture increases with the age because of ligament stiffening and cervical musculature matures. So regarding how to manage these patients and diagnosis, we should always and always follow the ATLS protocol for these children as well. Spinal immobilization via log rule precaution and application of hard cervical use should be initially performed in all children who have sustained trauma, given the possibility of spinal injury and instability. Someone asking the question regarding which type of collar, preferably Philadelphia collar. If not available, hard cervical collar is must for these patients. And there are two important things that we need to remember while transporting these kids, because they have relatively higher size of head. So either we should have we should have a support in our neck, in our board, so that it can provide extra support to the head of the patient, or we should have a collar at the level of neck, so as to avoid hyperflexion injury and further secondary spinal cord injury to the patient, as well as the airway closer to our patient. Okay. So patient with thoracolumbar trauma, after stabilization of general condition, this should undergo routine neurological examination if it is possible. In majority of the time, it was very difficult to take the history as well as like neurological, because the kids are not able to tell us exactly. And patient with thoracolumbar spine, they have associated like intra-abdominal, intrathoracic and head injury. These are the patients that they require a regimented approach for the physical examination of head, chest and abdomen, as well as the screening via CT scan. So my next talk, like the radiological imaging, routinely we do X-rays like AP and lateral films. But regarding CT scan, there is a high degree of consensus, unanimous consensus is not there, because some people say because of radiation hazard, CT scan should not be performed early unless the patient is having the upper cervical spine injury or patient is having associated polytrauma. So in that cases, we need to screen by CT. Otherwise, MRI is increasingly used to evaluate these injury because of the lack of ionizing radiation. and ability to access injury to the soft tissue, including ligamentous disc herniation or a neurological structure destruction. So MRI is friendly to the kids. Regarding management, patient should be, after the stabilization of the patient, we should assess whether the injury is stable or not. If the patient injury is a pediatric spinal fracture is stable, then we should manage these patients non-surgically. And I'm telling you, majority of the thoracolumbar trauma are managed non-surgically if the patient is having a stable fracture. For the stability, we need to ask whether there is a deficit is present or not. So if the deficit is present, then we require decompression surgery. Second, if the fracture is going to heal or it's having any reforming potential is present or not, whether there is a deformity is present or not. In that case, we require operative intervention. So what is the pattern? How to decide which type of fracture requires surgical intervention or not? For that, the classification, there are various classifications right from 1929. The first classification given by the Barn. Then afterward, that was modified by Dennis. He has given the 3-column concept. Then again, that was again modified by modified Dennis classification came. And recently, AO spine group classification is coming. And we usually follow this AO spine group classification along with the Tillich score. Though application in the pediatric population is same, but still there is the research is more upcoming how to implement these classification in cases of pediatric population. So what are the pattern that we are getting in these fractures? There is most commonly the fracture pattern that we are getting is the compression fracture. Is a lower energy axial loading force, that is a usually hyperflexion injury. In that cases, majority of the cases that there is a less than 30% of the height loss of the anterior vertebral body. Because of the wedge shape of the vertebral body in kids, they are more prone for this kind of injury. If the height is if greater than 50% is lost, then there is an associated PLC injury, and that requires thus MRI for the evaluation of these kids. This is an X-ray I have taken from a paper because I thought this is interesting to tell you, because this patient is having multiple compression fracture of these vertebral bodies that has been evaluated through this hyster images. As we all see, these are the edema. So by just seeing this edema and there's a loss of height, though it is less than 20%, and just by giving bracing for these patients, they are going to heal up and they have good functional outcome. Regarding the burst fracture, the next fracture of the compression fractures, these are the burst fracture. Because of the retropulsion of the fragment in the canal, they are associated with the neurological involvement and they are usually unstable fractures. So they require operative intervention in the form of decompression as well as stabilization. In cases of kids, we usually recommend shorter stabilization until unless the patient has matured the spine. So because we want to prevent the future deformity in these cases because of the crankshaft phenomena, so in that cases, we usually prefer to go for the shorter fixation. There is a different entity found only in the kids that is called a vertebral apophysis fracture or vertebral apophysis ring fracture. This is also called a slip ring fracture. This is usually common at the L4, L5 disc. What we are able to see that there is a slipping of superior end plate of the ring apophysis that is present in the form of this flex of the bone that causes the compression of the cord. So it is present similar way like the disc herniation, and the management usually require the decompression of the cord. So interlaminar decompression will do good for this patient that doesn't require the removal of this fragment, but just the interlaminar decompression is okay for this patient. And then next is the seat belt injury, that is a commonly associated flexion distraction type of injury that is associated with severe abdominal trauma and most commonly L2 and L3 vertebra. There is sudden deacceleration that results in the direct compression of the viscera occurring between the seat belt and the spine with a flexion fulcrum placed at the anterior vertebral body. And that's why these kids, if the patient is having a history of the motor vehicle accident, we need to find out the sign of the seat belt, whether this patient is having seat belt injury. If the patient is having the sign of seat belt injury in the form of bruises in the chest, then we should definitely look for the thoracoabdominal injury as well as the spinal injury for this patient. So there is a one case for the flexion distraction. There is a AO type C fracture. But we see that these are the fractures, the highly unstable fracture as well as the potentially associated with a neurological deficit. These fractures usually require stabilization. This is one of my cases that we have done. Longer above 2 segment down fixation. There is a peroperative stabilization picture of this patient. And we have stabilized by 1 level above, 2 level above and 2 level down the fracture side. This is a follow-up X-ray for this patient. This is a post-op X-ray for this patient. So And there's a traumatic example earlier. In that cases, we need to stabilize this fracture and realign this patient. Okay. In the last, there are a few words regarding skyora. This is an objective sign of acute traumatic myelopathy in the absence of any bone injury on the plain radiograph or a CT scan. But with the advent of because it was given in a way back when the MRI was not available, but with the availability of MRI, we are able to find out the injury to the spinal.
90% of fractures are stable. If you see the ossification, the iliac bone, ischial bone, and pubic bone, they arise from 3 primary centers, which fuse by the age of 14 years. And triradial cartilage has symptoms can be like pain and inability to bear weight depending upon the trauma. It can be even hemodynamic instability. If we see a child unconscious coming to the triage and we want to rule out the pelvic injury, there are certain telltale signs that there can be superficial hematoma along the inguinal ligament, and that's called the Distraught sign, which may indicate a pelvic fracture. The child may be having a rotational deformity or limb length discrepancy. A Ruse sign when there can be a displaced greater trochanter and the pubic spine, that difference in lateral compression injuries, the distance is reduced. Earl sign, a bony prominence or a large hematoma in the rectal area on examination. So standard X-rays, trauma series, spine, and to rule out other injuries. For pelvis, you have pelvis with both hip AP view, inlet-outlet views, and to assess the stability of pelvic ring, there can be, most important is when X-rays are not properly showing the fractures and there are subtle injuries. The investigation of choice becomes the CT scan, as 30% of pelvic fractures are missed on X-rays. CT also provides the triradial cartilage status if there is a risk of epiphysiodesis or if there is a joint incongruity. The topic is basically on how these fractures are different from adults, and we start with the classification only, that the Torrens and Zeeks classification is commonly employed in the pediatric age group, and it has 4 types, and mostly up to type 3, they are stable unless until they are grossly displaced. And type 4 is an unstable pelvic fracture, which is more than 2 millimeter displaced and may require an operative stabilization. So in Torrens type 1, usually there is a version of spinous processes, and this usually corresponds to secondary ossification center, which are attached to high muscular unit. And as there is a violent contraction, these spinous processes can avulse. Most common is the ischial avulsion, which occurs in 54% of population of such injured cases. Because of contraction of hamstring and adductors. Next is AIIS, where rectus femoris is attached, and a violent contraction can lead to avulsion of the spine, inferior spine. So mostly the treatment is again non-operative. However, these fractures should be seen very clearly because secondary ossification centers are often misdiagnosed as fractures. And if they are mostly displaced, then operative fixation for especially the ischial tuberosity, which is the most common, very well conservatively. Torrens type 2, 3A and 3, that is more severe. The injury per se is not that difficult to treat unless until very displaced, but this secondarily complicated by polytrauma to the abdomen and chest, and that's why the ICU admission rate, blood transfusion rate, and hospital stay is prolonged. Torrens type 4 is a pelvic discontinuity, both anteriorly, posteriorly, maybe bilateral, and this is somewhat a severe injury. Usually it is associated with the mortality unless until treated very emergently in the triage by a multidisciplinary approach, as told earlier. So we also follow the TILES classification and Pinel's classification, where type A are stable injuries, type B are rotationally unstable, usually open book, and vertically stable. Type C is both rotationally and vertically unstable. AO classification is also what is important in these pediatric pelvic injuries is the associated injuries are the leading cause of mortality, and life-threatening causes do coexist in up to 60% of the cases. However, bladder and urethral injuries is present in 15%. The lumbar plexus injuries, though rare, because posterior arch fracture is there, but it is rare and present in 3% of cases. A dedicated team of anesthesiologists, pediatric, the most common in adults is usually APC, and the higher rate of single wound pelvic ring fractures occurs in children. Why there are so many differences? Because the modulus of elasticity of bone for pediatric pelvis is low. Hence, the bones are more malleable. They can absorb high diastole tube well as the child grows. Presentation, the direct impact injury as the pelvic volume is low and trauma is high energy trauma, open fractures and severe soft tissue damage with visceral injury is more common. There is lower rate of hemorrhage, secondary to smaller vessels, also a good phenomena of vasoconstriction, and that's why the hypovolemia and hemorrhagic shock is not the cause of death, as in adults, which is in 3.4% of cases. Less than 1% of patients in pediatric population die because of hemorrhagic shock. Thick periosteum limits the displacement, making hemorrhage less common. So mainly coming to the conservative management, the stable fractures. Is the screen gone?
The screen has gone.
Okay. Some problem. So mostly they are stable fractures, and like tile A can be managed by pelvic binder and traction. The partially stable tile B, the pubic symphysis fracture, less than 2 cm displaced, minimally displaced, incomplete posterior ring fracture, again can be managed conservatively. The tile C for surgical intervention, if once it is stabilized, then they can be seen there. In conclusion, pediatric pelvic injuries are infrequent, but if they are suspected, then other associated injuries must be ruled out. And pelvic fractures, they differ from adults in terms of incidence, anatomy, classification, and good results of conservative management. Long-term follow-up is required, despite an initial satisfactory, successful operative and non-operative treatment. Thank you.
Thank you very much, sir. It was indeed a very brilliant talk. So today we have completed all the 3 excellent lectures on pediatric spine and pelvis injuries. And now we move on to the question and answer session. I see some of the questions in the chat box, and some of the questions have been messaged. So my first question to Barun Agarwal, sir. So what are the indications for flexion and extension views in a patient with cervical spine injury?
So you see, actually, after the normal trauma series, that the AP, lateral, and open mouth views are must. But still, if you find that the pain is persisting, there may be subtle instability, and the best views to dynamic, and that is where flexion and extension X-rays really help, especially in C1, C2. You may find a normal X-ray, but when the patient flexes, the C1 moves quite ahead than the C1 with respect to the C2. So especially for C1, C2, I try to do these kind of X-rays, and especially when there are the symptoms are persisting with the normal radiology. These X-rays do give us some additional clues.
But if we do it, if we plan for an operative fixation, we can do it intraoperatively when patient is sedated and seeing the CM image.
See, Dr. Shivam, when we talk about any surgery for spine or
for
trauma, see, if the X-rays are obvious and there is an obvious injury, then you don't need to have dynamic X-rays. Dynamic X-rays are always for the subtle changes which you are not picking up on the regular X-rays. So if it is a clear-cut case, you need to fix anteriorly or you need to fix posteriorly, then these during surgery, these X-rays would help you to assess the stability, that whether your fixation has achieved the desired result or not. But pre-operatively, even during surgery, may actually put more harm to the spinal cord, to the neurological structures. It is only for these subtle, X-rays where on the normal routine X-rays it's not visible. And even when I do order these kind of X-rays, always my resident goes along with the patient. That if the patient starts to develop any neurology, Any signs, just stop there. So you should have a high index of suspicion and things like that, and it carefully. It is not a casual procedure, especially for an unstable kind of a spine.
Right. So one more question to you: whether pediatric
Varun.
Yes, sir.
Whether still we need this stress views.
So, like I said, sir, MRI picks up your neurological involvement, but the spinal column instability, which is not very apparent on a routine X-rays. Even you see MRI is done in a supine position, but instability manifests when the patient is sitting, walking, or in the upright position, and he is not responding to your conservative methods. MRI is normal, neurology is not there, pain is persisting. Do you need to carry on the collar for a longer time? Things like that, those things you need to assess with the dynamic X-rays. So it is a very judicious kind of a decision for ordering. It is not in routine that we do it for all cases, especially in the pediatric population.
Right.
Okay.
So one more question to you, sir: whether pediatric cervical?
So
yes, then how?
Very good question. It is absolutely different ball game. Anything pediatric is a totally different ball game. The bones are small. The screw sizes sometimes are not even available. The case I showed where I did the anterior fixation in C1, C2, the bones were so small that the regular lateral mass, the bone was not big enough to accommodate those lateral mass screws. You may need to have alternative strategies. You may need to resort to the older techniques of wiring. Then you may not have those small size plates, small size of implants readily available or even at all available. So all these things need to be considered when you do small children, especially those below 5 years. All these things need to be taken. Apart from that, their physiology is also different. Even 100 or 200, 300 ml blood loss may be devastating to the child. For us, 200 ml blood loss doesn't mean anything. But for a 4-year-old or a 2-year-old kid, 200 may land upon into vascular compromise. So all these things need to be considered. It has to be multi-speciality management. Don't hesitate to involve the PICU people, the neurosurgeons and the pediatricians, the intensivists, especially so much of emotion attached to these kind of patients, where the entire family gets disturbed, a small child.
Different, like a school of thought. One says that there is no harm in giving studies, that there's always this debate is continues from a longer period of. So it's always if your patient is not having any contraindication for a study for kids, it's not an issue they are diabetic in older age group. So we consider the gastric perforation problem is also there in case of this high dose of steroids. So for that, we need to be vigilant before prescribing. It is not always that you have given a steroid and there is a lot of complications that are associated with the steroid. So we should not, because the steroid that has been recommended is a very high dose as compared to the normal steroid. And regarding the kind of steroid, this is solimedrol that has been recommended. But in our general scenario, if the patient is not affordable, because it's a bit costly. So if the patient is not affordable, then you can also give this dexamethasone. It's a cheaper one, and it's definitely a good alternative that we use in our cases of post-operative neurological involvement. If iatrogenic neurological involvement is there, then in that case, the role of steroid is definitely there, and there's enough literature for that. But regarding this trauma patient, because the injury that happens is because of the first hit. That trauma, whatever that happens to your cord, it's a final thing. And majority of the time, it's not going to be reversed. It depends on the time of trauma. So the role of steroid, if the patient is coming within 8 an hour, they say that the NASA's trial that says that the patient is coming to you within 8 an hour, it's impossible that you are getting, it's very hardly. There's really a major group of patients that you are getting within 8 hours of injury. So the role of steroid is very controversial, but still, if your patient is affordable and you can feel there is no harm, if the patient is not having any contraindication to steroid, then the group says that you should start steroid. If the group is not having contraindication. Otherwise, there is absolute no for this steroid.
So any time limit for giving steroid if you are prescribing it?
That says within 8 hours, if you are getting your patient, then you should start 5.4 milligram per kg body weight as per the body weight. 5.4 milligram per kg body weight you will have to start over the period of 24 hours. One trial says that over the period of 24 hours that you need to grip, and there is NARCISS 3 trial that says over the period of 48 hours, this amount of steroid need to be given to your patient.
Right, sir. So there's one more question for you. When to go for a fixation in vertebral apophyseal fractures?
Usually these fracture doesn't require any surgical, fixation, they doesn't require. They are very stable sort of, because there's just a herniation of a end plate. So just a interlaminar decompression will do the job. You don't require to remove any facet or some anything. So for that, they are very stable type of, because laminectomy doesn't warrant any fixation. If you are going to remove a facet, suppose if it is at the higher level, then at that time, if you are removing the facet, then at that time you require a surgically fixation. Otherwise, only interlaminar decompression will do the job. That is not required. You doesn't require any fixation for this.
Sir. And sir, do all patients with posterior ligamentous complex injury require a surgical intervention? Talking about pediatric patients.
Definitely, if the patient is having surgical intervention, definitely if the patient is having like PLC injury, because as we follow up these patients, they may land up in the deformity. So it's better if the patient is having deformity to fix it up now, because you require a smaller amount of surgery in comparison to if you will need to correct this deformity at the later of, like the patient is like getting, because there are two complications if you are not fixing at the one time. There's a post-traumatic kyphosis that is going to be developed, and in some cases you are also going to get a late involvement of the neurology. So in that cases, you are at that time you require a larger amount of surgery. So it's better to fix it now as compared to the later.
Right. Right.
Yeah.
Varun sir has to say something.
Yeah, so like sir was asking, what is the indication for flexion and extension X-rays? One of this is the PLC injury. Only these dynamic X-rays, in the absence of any neurological deficit, are able to pick up these kind of subtle injuries.
So there's a question for Shivam sir. How do you apply a pelvic binder?
Pelvic binder is essential for the pelvic injuries where we suspect an open book type of fracture, and we all know we have to reduce the pelvic volume. So in pediatric population, you have to maintain the immobilization of the cervical spine because they are injured in multiple systems, including the spine. So you log roll the patient, position the pelvic binder posteriorly on the back, then make the patient's spine at the level of greater trochanter, give the pelvic binder, and tighten it along the pelvic symphysis. So just to maintain it, if you have a pelvic binder there, you can use it, or you can use the sheet, operating table sheet or cloth, and clamp it with the help of faucets. The important is that the level should be at the greater trochanter and focusing on the pelvic symphysis.
Thank you, sir. So there's one more question for you. What type of acetabular?
Sir is saying something.
Yeah.
Sir is making some comment.
Sir, you are not audible.
Hello.
Yes,
Yes,
sir.
sir.
Hello.
Yes, sir, you're audible.
Yeah. What I'm saying that it is very important to understand that the pelvic binder should be at the level of trochanter, as Shivam have said, because I have seen pelvic binder at the level of umbilicus. That is only cosmetic. So pelvic binder should be at the level of trochanter so that the compressive force which is required can be applied. Thank you.
Thank you, sir. So one more question to Dr. Shivam, sir. What type of acetabular injuries may later on develop into acetabular dysplasias later on?
See, we have that Lanscomb's classification. Even the acetabular injuries, you see all the classification I told. And if it is through the physis, if it is a crushing of physis there, a displacement of physis, this physis will continue to grow because the acetabulum grow with interstitial grow and lateral calcification. If the physis is disturbed, and that is why it need to be evaluated very thoroughly with the help of, at times, maybe MRI or a CT scan. If it is disturbed, this will lead to acetabular dysplasia. Posterior lip fracture, not going through the physis, yes, it will be presenting with instability. That is what is important. That is what is stabilizes, and the joint continuity is not there. Definitely, this will lead to dysplasia.